I thought I'd start first by talking about PAD, and then we're going to talk about CLI. And I'm going to go into PAD just because I think we're all aware of it, but maybe as a country and as a prognostic group, we're not always thinking about the importance of this. We often talk about the big three: cardiovascular disease, cerebrovascular disease, PAD. Of course, all atherembolic diseases together. If you think about the traditional papers that are in print or in press about prevalence of these diseases, coronary heart disease, of course, is recognized much, but the incidence of PAD on this slide, you'll notice, is not known. People are unaware of how often every year people develop PAD, much less CLI, although we use surrogates such as amputation, wounds, and other things. There are some recent data that I'll show you. The 10-year risk of atherothrombotic events in patients with vascular disease, again, from the guidelines and other documents, are pretty well known. PAD increases your risk of MI and cardiovascular death 4 times, and stroke with TIA 2 to 3 times compared to what you see on the stroke risk factors. As you all know, until there's a wound or rest pain, a lot of our patients may not always present because it's not thought about as much as others have thought. The risk factors, as you've heard, are exploding, but I tell our fellows in clinic, if they don't have smoking or diabetes, they rarely have PAD or CLI. They, of course, have obesity, and these risk factors I think we're all aware of. So classic symptoms people have talked about, atypical symptoms. Mary McDermott, Bill Hyatt, and others have spent a lot of time saying, how often does critical limb ischemia happen? This is from the guidelines and from the New England Journal Review. 5 to 10% may have critical limb ischemia, but the actual number, I think many in this room would be wondering, if you're at a wound clinic, if you're places where you specialize, this is much higher. And if you look in the United States these days, I think the number is actually growing, and I'm going to show you some empiric data to show you that. The spectrum of PAD, I think, is well known to us in this room. It's the master's course. But if you go out to our clinical colleagues across the country, most will not understand that this is not a direct line. People don't go from having fatigue to mild, moderate claudication, then rest pain, poor wound healing. They show up in many different spectrums of disease that we'll hear about today. Well, I think about the population prevalence of PAD, and you might say, well, how common is PAD before you think about critical limb ischemia? This is data now that's fairly old from NHANES, Partners, and others that has shown us that, in fact, up to 29% of the population, if you screened everybody with an ABI over 70, or if they were diabetic over 50, and we're going to have more recent trial data to tell us this, but somewhere between 5 to 25% of patients, depending on the age group, may have PAD. And of course, as the population ages, PAD and critical limb ischemia are diseases of the elderly. Does anyone know what the average life expectancy of an adult in the United States is today? Women, it's 82. Men, it's about 78 to 79. That's going up every year. And, you know, kids born today may be anticipated to live out to be in the mid-90s. So the baby boom is upon us, and PAD and critical limb ischemia are atherembolic complications of that. Mary McDermott has shown us that as you get older and as your walking declines, you get worse PAD. And this data shows us that your actual decline in 6-minute walk performance, people stop walking. Eventually, the atherothrombotic burden gets so high that people stop moving their limbs. Well, what's the contemporary prevalence of PAD? I think this first paper is one that maybe some of you have seen. This is from Jerry Folks, and he and I and others work together on some national data sources, worldwide data sources. Jerry has done a very impressive analysis that was published in Lancet 2 years ago. This is a comparison of the global estimates of prevalence and risk factors of peripheral disease from 2000 to 2010. And I'll just highlight for you that we often here in the United States are talking about PAD, and if you look on this slide, you'll see that across many different sections, there's sort of a burden as age goes up. You see what the actual prevalence of PAD is, with the blue bars being the oldest patients, those over 85 and then 75. But shockingly, those purple bars being people that are 25 to 35. And if you look, and this is probably something we're starting to see in the United States too, Southeast Asia, China have exploding rates of atherembolic disease in younger patients, critical limb ischemia occurring in Japan, China, and India across the world in many younger patients. So the clinical course of PAD with critical limb ischemia is an important clinical issue. Of course, that's why we're here, and this is the Task 2 statement on what's the prevalence and occurrence of amputation and death. Skylar Jones and some of our colleagues published this, and maybe as a way of thinking about it, we're going to hear a lot about staging, whether it's classical staging, Wi-Fi staging, different ways of staging our patients with critical limb ischemia. But one of the things we're really missing is the prevalence and epidemiology per those different types of classifications. We don't have a standard way that we're all evaluating our patients, I think, in our clinics, and therefore it becomes harder to measure our outcomes. So what's the true epidemiology of critical limb ischemia? I'll say it's difficult due to definitions. There's a lack of high-quality data to date, but I'm going to show you the best I have in a second. And is it critical limb ischemia versus amputations? You've heard inpatient samples of patients getting procedures. I'm going to show you some of the amputation data you saw a bit of, and prognosis, staging, and concomitant therapy. We're going to hear a lot about master's approaches to revascularization. I'm going to share you a few slides about what I think are some of the medical therapies that are coming down the pike that may also affect how we think about critical limb ischemia. So the two major issues are symptom improvement and cardiovascular risk reduction and limb salvage in patients with PAD and CLI. And PAD of the leg is said to have critical limb ischemia 1 to 3% in the guidelines and 95% claudication. We now know that this isn't true. If you look at all-cause mortality by just patients with abnormal symptomatic lower extremity limbs, you see that it is under-recognized that PAD and critical limb ischemia may have 10-year mortalities worse than cancer. When you actually look at critical limb ischemia, I'm going to talk to you about prognosis in a second, it's still around 40 to 50% event rates at 2 to 5 years, maybe higher in the Medicare population. This paper, which I think is probably some of the most recent data that's worth everyone reviewing if you haven't seen it, is the Epidemiology of PAD and critical limb ischemia in Medicare in the United States, and this has been published by Mark Naylor, Alan Hirsch, Bill Hyatt, and others. In this data set, they took these codes, and it's valuable to see these codes. It's the best available codes we have, where they looked at our amputation patients, they looked at critical limb ischemia based on Medicare coding data. It's administrative data, and we all recognize some of the limitations, but they did do some chart validation, and they reviewed all of the sort of inpatient sample diagnoses, as Mehdi and his colleagues have also. This was published in the Journal of Vascular Surgery in 2014. And I think a couple of things, I'm sorry, I went the other direction. A couple of things from this data is important. First, you can see that there's actually two sort of bars. There's primary presentation of critical limb ischemia, and then there's sort of secondary presentation of critical limb ischemia. Patients that have bad PAD with significant hemodynamic limitations don't get much done to them, or just seen in Medicare and then show up with critical limb ischemia at some time point. If you just looked at the annualized prevalence, it's somewhere between 7 and 10% of this Medicare population. It's higher because they're 65 and older, but that may be why we think about these patients maybe as a group. If you look at primary presentation, it's about 7% of those patients. And then there's a nice breakdown by how many of them actually have atherosclerosis with ulceration, how many of them actually are coming with rest pain, gangrene, and amputation. If you look at actually, just for example, rest pain, it probably counts for about 40% of that primary presentation, whereas at the secondary presentation, there's more patients with ulceration. What about prognosis and outcomes? I guess that's our incidence and prevalence, but how are we doing? I think some of this we know. This is from John Dormandy, sort of classic teaching. If you had 100 patients with claudication and you followed them, 75% of them stabilized, 25 deteriorate and eventually get intervention. 2 of them require amputation. Somewhere between 5 and 6% of them potentially get critical limb ischemia. Now we're starting to see some of that through that Medicare data that I just showed you. Classically, many have said that the symptoms may not follow in the natural history. Unfortunately for us, we don't have a tremendous number of registries and data to tell us about the natural history of these patients. If you look at this, the general prognosis of the mortality of the population at that age group is less than 10 to 15%. So if you looked at the task group, when it was first published, task 2, they said the 1-year outcomes of patients with critical limb ischemia, and I think Mehdi just showed you, alive with 2 limbs was 45%, amputation was 30%, mortality was 25%. We've now looked at Medicare inpatient sample data from Dr. Shishapur and others, and there we might see that we're actually reducing the mortality, but there is still a significant burden to these patients. This is the data from Goodney and others looking at our endovascular interventions. There is a reduction in major lower extremity amputation and a reduction in bypass surgery. This has now been shown on the inpatient sample, as you've seen. Post-amputation from Medicare, this is Dr. Jones and others from our group. Again, you can see that those that get an amputation have a significant all-cause mortality in Medicare, where if you get an amputation, your 1-year mortality may still be 40 to 50%. I'm going to show you these data specifically in a second. What about the risk factors if you're a patient with critical limb ischemia for having an amputation and then having mortality? This is the mortality model. This is the FinVasc, or the Finnish mortality model. And you can see that the risk factors are diabetes, coronary disease, foot gangrene, and urgent operation. And of course, the more of those points you get, the higher you are. Josh Beckman, Mark Krieger actually nicely wrote an editorial on the 2-year intermediate survival of patients with critical limb ischemia. This is in JACC intervention. And again, you can see that there's a broad set of risk factors. You can use a variety of them, that they tend to highlight 2 things or 3 things. First, the urgency of the operation, the degree of tissue loss, and renal dysfunction, another large driver for our patients with critical limb ischemia. But unfortunately, even though we've had some improvement, if you look at the trial data to the registry data, we continue to have pretty significant 2-year mortality. In basal, I'll just remind you now, many years ago, balloon angioplasty versus surgical revascularization, the 2-year mortality was 26.8%. Recent Swedish registry data, 27.8%. U.S. amputation and mortality in Medicare, above 25% at 1 year. So despite our efforts, we need everyone here, as Dr. Sheshapur said, because our event rates are still very high. He showed you this slide from Dr. Jones. This is a little bit more blown up. This is the regional amputation by hospital coded region. I live in North Carolina, so unfortunately I am in the stroke, hypertension, amputation belt, but there are many counties and places where there's regional variation that cannot just be accounted for by the patient population. From that data and others, there is a trend to reduction in amputation in the United States across all regions with the intensity of vascular care, so that is reassuring. And as you know, there are many tests we can do for our patients with PAD. Dr. Vemlapalli from our institution did a Medicare data published in CIRC Outcomes in 2014. This, I think, is a staggering fact, and at least best we can tell from the data for billable procedures. Now, people might use Dopplers in their office, but 30% of patients didn't get an arterial test prior to an amputation in the United States. 30% of patients didn't get some sort of arterial testing that we could document prior to an amputation in the United States. So before we even get into procedures, before we even get into what other things we do, primary amputation occurs at a fairly large rate still in the United States without an attempt to identify if there's an arterial cause. The high mortality, as I just mentioned, this is Medicare data too, and you can just look across the top line. This is 1 month, and then the PAD without lower extremity amputation, PAD with amputation, so not all critical limb ischemia patients, but if you just looked at all-cause mortality, the rates get pretty high. At 1 month, if you had an amputation, it's 13% in Medicare. At 1 year, it's almost 48% if you get an amputation of any sort, and we believe you have PAD in Medicare. So 7 to 10% of the patients have it, and they still have poor outcomes. Medi spent a moment on this. I won't spend a lot of time just to say I was, for the HRQ, I presented some of the data for the existing data for the MedCAC meeting. $4.37 billion are spent on PAD. This is how PAD compares to CHF, cerebrovascular disease, cardiac arrhythmias. The country's going to care about how we do it. We obviously have to do it better. There are missed opportunities. Dr. Superwall showed us in Denmark that patients with PAD don't have aspirin and beta blocker use and statin use at the same rate that patients with coronary disease do. So I'll just conclude by saying the incidence of critical limb ischemia is 1.5 to 2% in Medicare. The prevalence is 7 to 10%. The survival doesn't seem to have changed. Amputations still occur at 25%. You've heard about high intensity. Amputation rates are decreasing, but there is regional variation. I'm part of this trial called the Euclid trial, testing ticagrelor or clopidogrel in patients with PAD. This is 13,000 patients. About 5% of these patients have critical limb ischemia. We're going to have long-term data on these patients, and hopefully we'll present that at AHA. Thank you.
So as you may know, normal healing occurs as a cascade of both biologic and physiologic events. And essentially, that cascade needs to proceed in an orderly fashion from hemostasis through those stages. So we have a very unhealthy appearing wound as pictured on far left through those various stages to that of complete skin closure and remodeling. And that process occurs over time through a variety of different mechanisms. But the real question becomes then, for those patients with impaired healing, what is the cause of healing? And really the foundation begins with that of an accurate diagnosis. So obviously the focus of this meeting, those being with significant PAD and CLI, but once we have that accurate diagnosis, wound healing really then becomes a balance of many factors. Some of those include the following: certainly optimizing perfusion as per this meeting, controlling edema, looking at infection and controlling such, performing appropriate wound debridement, offloading, certainly accomplishing tissue moisture balance and moist healing and systemic disease management. And the list goes on and on. This is by no means a complete list, but certainly some of the factors that are involved with balancing healing. So again, that accurate foundation becomes the critical point. And we'll focus on a few of these this morning. So arterial ulcers, as you know, classically have a full thickness tissue loss with a very punched out, well circumscribed appearance. The bases can be fibrous or fibronecrotic and may or may not involve bony prominences, typically are painful for those with intact sensation. Certainly the extremity can be cool with certain skin changes being pale and shiny. You can see areas of tissue loss pictured here on both the hallux and the heel, just due to ill-fitting shoe gear in the presence of significant arterial occlusive disease. So again, according to this meeting, perfusion assessment becomes critical, and what you'll hear through various speakers throughout the course of the meeting are some that tout the angiogram approach to wound care. So perhaps the new standard, not just establishing direct inline flow to the extremity with tissue loss, but direct inline flow specific to the area of tissue loss. And this is described actually in the mid-'80s, in the foot at least 6 geographic regions fed by the 3 and 4 popliteal vessels, and we'll look at cases specifically where we've reestablished direct inline flow to establish healing for tissue loss. Another component of basics of wound assessment is that of edema, and certainly we see patients with tissue loss who have significant volume in the leg. What's pictured here is classic venous stasis ulceration. You can see a fairly ill-defined area of ulceration in the medial aspect of the lower leg, but with the classic skin changes and certainly tense pitting edema in the lower leg. And the hallmark of therapy for a lot of those patients is aggressive compression therapy with various wraps and other modalities to facilitate reduction in volume, and you can see on far right that reduction results in decreased wound surface area. Those skin folds are actually a desirable outcome, but for those with significant PAD, that may not be the standard. What's pictured here is an example of a 51-year-old lady who had treated presumptively for venous stasis ulceration of 8 months duration. Now, she was treated with oftentimes the standard of care, which is sequential layer wrap applications applied once weekly with serial debridements. Unfortunately, after 8 months of such therapy, she still had non-healing. Again, this goes back to the primary teaching point being to establish an accurate diagnosis. You can see the wound itself has a fairly unhealthy appearance, but the surrounding skin has an atypical appearance as well. A raised violaceous border, and probing with an applicator reveals circumferential underlining. So again, that accurate diagnosis being key here. This is an example of pyoderma gangrenosum, an atypical ulceration that doesn't respond alone to compression therapy. What about patients with mixed arterial venous disease? Challenging in that the strategies are usually polar opposite in terms of optimizing perfusion versus reducing volume. So a lot of artistry to titrating compression so as to safely reduce volume but not creating any occlusive, precipitating any worse occlusive disease in the distal periphery. An example of such, the 61-year-old diabetic lady with anterior shin ulcers of mixed etiology. Angiographically, significant diffuse tibial vessel disease, not amenable to intervention or bypass. So as such, we had to use a very careful approach. Rather than a layered compression wrap applied once a week, changes daily with absorptive dressings and enzymatic debridement. After a 6-week period, you see resolution of satellite lesion, the primary lesion reducing in size. And finally, after 13 weeks, a slow go as due to that concomitant arterial disease, but you can see she's been compliant with compression as evidenced by the depression of the skin from that secondary dressing. Now, what about getting the whole picture? Certainly this patient has volume issues. You can see some of the venous stasis skin changes and hemosiderin staining, but taking a thorough history and physical and completing a complete exam is certainly important. So what if I give you more of the picture? You can see this patient's had some digital amputations with tissue loss in the hallux. What about the opposite extremity? Well, obviously patients had significant complications, both lower extremity as well as upper. You can see with significant tissue loss on the lateral column and heel. And when I give you the whole picture, 70-year-old diabetic man with renal transplant, multiple revascularizations, both upper and lower extremity with ischemic necrosis and amputation of both upper and lower extremities. You can see in this circumstance, certainly a patient with critical limb ischemia, and in this case, obviously, contraindication to any aggressive compression therapy for volume. So infection, we're going to hear from one of our later speakers this morning from the infectious disease section, but some basics when it comes to wound infection. Certainly, one of the basic things is not to leave dressings in place for extended periods of time. Although companies will tout the ability to hold these dressings for up to a week at a time, sometimes it's simply a matter of adjusting for the frequency of volume. So what's pictured here on the left is a very saturated dressing with a very unhealthy appearing wound that had been changed once weekly. Alternatively, when we change that dressing more often, at 1 week follow-up, you can see a much healthier appearing wound just by addressing the frequency of change. Certainly, when it comes to wound infection, there are hallmarks, as you know, in terms of looking for erythema, significant calor, tissue edema, the quality and quantity of drainage, significant pain, and I put an asterisk there because that may be masked in diabetic patients with neuropathy. Certainly areas of fluctuance or crepitance in tissue, and then depth. And when it comes to depth, it's important to remember a very basic of wound assessment to look at wounds not with just one's eyes, but with one's hands, and deep culture becomes important rather than just superficial swabs. An example of such is this diabetic patient with tissue loss in the posterior aspect of the heel. you can see through segmental pressure assessment that the patient does have some level of occlusive disease with a history of prior intervention, but one of the important teaching points from a clinical perspective, again, is to probe that wound. Despite a fairly benign appearance, it actually has significant depth of about 2 centimeters and probes directly to the calcaneus. So this patient had to be treated for calcaneal osteo. We also did diagnostic angiography. You can see diffuse popliteal artery occlusion here and disease below the knee. So with recanalization below the knee level, now we have much better flow to that area of tissue loss and are able to facilitate healing. Other aspects in terms of wound infection, utilizing appropriate imaging studies, so x-rays, MRIs, CTs to assess the extent of infection. You can see a patient pictured here with an example of previous partial fifth ray amputation due to pressure ulceration, now unfortunately with new ulceration into the first metatarsal phalangeal joint with septic arthritis and osteomyelitis of that joint, perhaps at this point then condemned to transmetatarsal amputation. It's important also to remember when it comes to assessing infection to look at diabetic patients in terms of being more thorough. Some of those clinical signs of infection, those hallmarks, may in fact be muted. This is a patient who had a partial first ray amputation. You can see a fairly unhealthy appearance to the wound. I was asked to chime in terms of healing capability, and we were able to offer some suggestions, but radiographically you can see a reasonable linear cut through that first metatarsal shaft. Unfortunately, the patient was lost to follow-up, decided to continue care with their local provider, and came back some months later complaining that he had stubbed his second toe. And he said, by the way, that little pesky wound hadn't quite healed as well. And being the diligent podiatrist that I am, I decided to repeat x-rays. Despite a fairly benign clinical appearance, you can see now, unfortunately, not only does he have irregularity to that residual first metatarsal, but also radiographic evidence of septic arthritis and osteomyelitis in the second metatarsal phalangeal joint. So again, progression to transmetatarsal amputation. Offloading, something certainly part and parcel to what we do as podiatrists. We say that callus is pre-ulcerative in nature and can lead to neuropathic ulceration. So we do a various number of different things in terms of offloading strategies, but certainly one of the basics to remember the opposite foot. So when patients have amputations, don't forget to offload pressure on the remaining extremity. Offloading devices are wide and variable depending on weight-bearing status, can go from things temporarily as offloading boots in the hospital to various shoes with modifications to total contact casts. So in conclusion, the ABCs of wound assessment really begins with that hallmark of a thorough history and physical exam. Ask the right questions and you get the answers you seek. And then that foundation of therapy begins with an accurate diagnosis. Once having established that diagnosis, address all contributing factors, certainly PAD and CLI, but also edema, infection, and abnormal mechanics and pressure points.
So the three main types of wounds that I'd like to talk to you today about are arterial wounds, venous wounds, and neuropathic or pressure wounds. So the big thing to keep in mind here is that most of our patients that come in are not going to be one specifically or the other. They're going to be an overlap of all the above. The various classification systems I'm not going to talk about today, secondary to time constraints, and I know the infected wounds will be talked about by Dr. England later, so we won't talk about that today. So the first type of wound is the arterial wound. You'll see this in a number of different vascular disorders, most predominantly atherosclerosis and diabetes. Increasing age and smoking predisposes these patients to getting these arterial wounds. Oftentimes these ones you'll see on the tips of the toes, any kind of pressure areas, on the malleoli, and under the metatarsophalangeal joints. So these wounds are not always going to present like this picture. You'll often see a tiny little punched out wound surrounding rubor, very, very painful. They'll have even wound margins. Oftentimes you'll see gangrene or necrosis, but not always. They're often dry and they don't drain very much. Clinical exam, again, pain out of proportion. You will hardly be able to feel pulses on these individuals. They'll present with thin skin, thickened toenails, hair loss, pallor on elevation, and rubor on dependency. Keep in mind that when you put that leg up and you put it down, it should come back to normal color within 20 seconds. And also something to keep in mind is that a number of the normal population will have absent pulses. Dorsalis pedis is absent in up to 10% of the population, and the posterior tibial pulse will be absent in approximately 2% of the population. Cyanosis is often present, as well as a diminished skin temperature. Diagnosis of critical limb ischemia varies in the literature, but typically it's considered an arterial pressure of less than 40 in the presence of rest pain or less than 60 in the presence of tissue necrosis. Critical limb ischemia is associated with a decreased quality of life and increased amputation risk, and these individuals are suspect to death within 5 years at 50 to 60%. Death often occurs as a secondary event to a coronary event or stroke. Treatment of these arterial wounds, revascularization is the mainstay, as we all know, hyperbaric oxygen, arterial flow pumps, stopping smoking, elevating the head of their beds while they're sleeping at night, treating their various comorbidities, encouraging them to walk, avoiding beta blockers, improving flow through multiple anticoagulants, and relieving pressure. Venous wounds, oftentimes we'll see these, a history of valve incompetence. These patients will have a history of blood clots, thrombosis, thrombophlebitis, venous stasis, and lymphedema. They have a history of leg ulcers to their medial ankles and their anterior legs. They'll be present in obese individuals and as well with advancing age. So what will the wounds look like? Venous wounds are difficult to see where it begins and where it ends. They'll have irregular wound margins. They'll be very superficial, surrounding ruddy granular tissue. These patients rarely experience pain, although they do at times. And the typical patient will present with ABD pads wrapped around their legs or towels to absorb all the dressing or all the wound drainage. Their clinical exam consists of edema, dilated superficial veins, dry, thin skin. They'll often have evidence of old healed ulcerations, shiny skin, peri-wound and leg hyperpigmentation. And this is a good example of lipodermatosclerosis, which is hard, indurated, scaly skin present from scar tissue from severely uncontrolled venous stasis disease over time. Treatment for these individuals, graded compression, multi-layer compression dressings, such as an Uniboot, compression stockings, pneumatic devices, debridement, mainstay of all wound, except for arterial wounds, and skin grafting. Finally, our last wound type is a neuropathic wound. You'll see these most commonly in a diabetic with peripheral neuropathy. But keep in mind, this can happen with anyone with neuropathy. And there's a number of different disease processes that can cause somebody to be at significant risk. When I was in residency, this was one of the mnemonics they taught us, to keep in mind all the different individuals that would suffer from potentially diabetic neuropathy. And you can see here, it extends much further than those with just diabetes. So what will these wounds look like? They'll have even wound margins, oftentimes associated with cellulitis or osteomyelitis. They're often deeper than other wounds. They're almost always surrounded by a thick, heavy callus. You'll see granulation tissue often, unless there's significant infection present, and these wounds will be low to moderately draining unless, of course, there's presence of infection. On clinical exam, these wounds are not painful. You won't have significant sensation in these patients. They're usually neuropathic. They'll often have pes planus, pes cavus, hammer-toe deformities, bunion deformities. You will feel pulses in these individuals often, but not always. There's typically a warm foot, and the fat pads often atrophied and shifted to a different direction that's responsible for why these wounds are developing in that location. So the mainstay of treatment for these is debridement. When I was in residency, the mainstay was saying it's not what you put on a wound, but it's what you take off. So making sure you offload. I'm not a big fan of a surgical shoe, although that's the mainstay when patients come to see you. They're often in a surgical shoe and nothing else. I prefer total contact cast, which is ideal for the slow or non-healing wounds, or a cam boot with offloading. Controlling the diabetes, controlling infection, and assessing nutrition where necessary. So just a couple of questions. I don't know if we have the audience panel. Okay, so just enter your choice, A, B, or C. What type of wound do you think this is? Does it come up for texting? No? Okay, so this is a venous wound, I think pretty obvious. This patient, venous, arterial, or neuropathic wound. You can see here, let's see if I can figure this out. So you can see under a pressure point, right underneath the metatarsal head, significant callus surrounding the wound. That's a neuropathic wound.
Gina, excuse me.
Mm-hmm.
The panel in front of your hands, you can vote with the panel in front of your hands. So these are questions, you can answer them, and you can then see your response on the monitor. So just use the panel in front of your hand to vote, please.
So this is a significant example of a complex wound. So you can decide here, we've got A, B, C, D, or E. This patient is an insulin-dependent diabetic male. I'll tell you he has absolutely no pain with debridement. And he has had interventions, as you can see here. So what does everybody think for this one?
Can you get the audience response?
Is it working? So in this wound, we'll say this, all of the above. This is another wound, 56-year-old insulin-dependent diabetic female. Again, we debrided this entire wound without pain. She is supposed to be wearing compression stockings, but of course she's not. And this was post-debridement for her. And any ideas about which type of wound this would be? And again, I'll just beat to the chase and say this is an all of the above wound as well. So mix of a number of different things. And this was her healed. Took over a year to heal this ulceration on her. And this ends my presentation. Thank you very much.
So on to the topic at hand, understanding your patient's feet. When I'm talking about understanding your patient's feet today, I really want to speak about those of our patients who have diabetes, which do encompass much of the discussions throughout the discussions over the next 3 days. And of course, amputation has been mentioned by Dr. Patel. I'll touch on that for sure because this is the greatest fear of our patients who have diabetes and definitely a risk factor for those with CLI. Of course, our diabetic patients, for the most part, want to take the path that is not on the route to amputation, of course. So let's understand our patient's feet, but also the patients that are attached to those feet, and limb preservation, if at all possible. It's been said that it is one of the most feared complications of diabetes. True. I don't think anyone can dispute that. It's a catastrophic complication in individuals with diabetes. Of course, sometimes inevitable, but it still is catastrophic, and we have to understand that. And more than 60% of the non-traumatic amputations do occur in our patients who have diabetes. But amputation isn't the only culprit. Let's understand our patient population. As Dr. Shishabor said, these are sick patients and only growing sickness. And what we see is that whether they have PAD, a healed diabetic foot ulcer, Charcot, or a below-the-knee amputation, mortality is great. I like this. It's a very old statement, an old proverb or quote from a Chinese doctor, but superior doctors do prevent the disease. And isn't that why we're all here today, to help in that preventive process, to perform procedures and take steps to prevent the ultimate amputation and the most blasted of the diseases. And here's a poll of over 500 patients, and we can see that, in fact, that a below-the-knee amputation is greatly feared, more than death. And I know I have heard that time and time again. I'd rather lose my life than lose my leg. And how true is that? And whether we might dismiss it and kind of poo-poo that, it is actually true in the sentiment of our patients, and can we blame them when we know that the mortality is great, worse than most cancers? In fact, within a 5-year time. And as the life expectancy decreases, each subsequent segment of the leg is amputated. We don't have those high mortality rates yet, reported at least, with toe, foot, and below the ankle type amputations. Amputation does conjure up other potential risks as well, as we know: osteoarthritis, back pain, joint pain, osteoporosis, osteopenia, and perhaps the greatest risk is the quality of life, a reduced quality of life. We don't want that reduced quality of life for our family members, so why should we want that for our patients? So we have to recruit the right team members, right? We have to work on those who are passionate, who are deliberate, who are collaborative. And I have two stories I have to share with you with Dr. Shishabor because I just love them. A few weeks ago, he called me. It's 8:15 in the morning. He calls me on my cell phone because that's like how he likes to communicate. And I'm in clinic, and he's in the OR, and he's practically jumping up and down. The music's blaring in the background. You know, he's definitely had breakfast that day. And he said, oh, we've just restored, we did the anterograde distal approach, and we got the dorsalis pedis open, and we got the perineal open, and he's got great circulation out of the foot. And, what are we going to do next? It makes you want to heal that ulcer or that partial first-ray amputation better when you have someone that's pulling for your patient, doing their best, taking not just a one-time effort, but a two-time effort to reduce the risk of amputation and increase blood flow. This was another patient I had to share quickly, too, because this patient came to him on February 9th for a second opinion. She was told that she was going to have an above-knee amputation or she'd become septic and die. She was with her daughter. Her daughter brought her down to see Dr. Shishabor on February 9th, took her out of the hospital, and on February 10th, she was on the table, having intervention, angiogram, and a distal approach to improve her blood flow. And yes, a week later, we did the TMA, and then this is the most recent picture I have, but I can tell you today she's got a foot orthotic, a shoe, and she's now home out of a skilled nursing facility from February 9th after being told she would have an above-knee amputation early February. So these are the types of cases that we love and we become passionate about, and that's why we're here today. We all have different tools in our toolboxes. For me, probably the number one goal and outcome that we have to do is educate our patients. As a podiatrist, we need to use all our tools in our toolbox and identify who is at risk of amputation, who has loss of protective sensation, who has peripheral arterial disease. When we can't feel a pulse, we don't stop there. We can send them to the vascular lab, but we also have to bring out that handheld Doppler. The biothesiometer and the monofilament are my go-to for loss of protective sensations. There's 5 neuropathic tools, but those two are my two. Also, the temperature sensor. Who is going to develop that foot ulcer? Who's going to break down? Who has deep inflammation? We can tell that with that temperature monitor. This goes back to the 1920s, really the forefather to a collaborative team approach and a diabetic foot-centered disease with multidisciplines comes with Dr. Elliot Joslin at the New England Deaconess. He was the first to have a nurse educator. He was the first to really push glucose control and glucometers and now established people with podiatry, orthopedics, vascular surgery, and grew that. Then there was Dr. Paul Brand. He had some different players in his team, but he still had a team goal set to reduce amputation, biomechanically give those foot orthotics, debride wounds, offload, the total contact cast. He's the forefather for that. And we have those examples. Throughout Asia and China, we have multiple studies that demonstrate that collaborative team, multidisciplinary approaches reduce amputation. And it's quite great. I mean, 82%, 70%, all across the board, great reductions to major lower extremity amputations by working together. And they're not the same model. Some include endocrinology, podiatry, some more intervention, more vascular surgeons. There's different approaches, but working together and finding and recruiting your team can really pay off for our patients. And we can see that, like Dr. Patel showed, the mass reduction in lower extremity amputations from 2000 to 2010 by Medicare. I do love this paper in 2013 that looked at, as the Medicare population grew, they queried the Medicare Part B claims and looked at amputation codes as well as some procedure codes with orthopedics. While the only thing that really increased was our population and toe amputations, the other thing that was really looked at here, it was really consequential, was the orthopedic diabetic foot treatments for ulcers increased by 143%. That includes just minor procedures, gastroc recessions, TALs, and total contact casting, which I employ regularly. And with that, the decrease was the lower extremity amputation rates fell dramatically. So despite increased patients, decreased major amputations, including even partial first ray and Chopard amputations. We looked at our own data. We actually published in JAPMA in 2016, January, about our iatrogenic rates in the total contact cast, because that's one drawback from patients using total contact. But what we found is, similar to that last study, is exponentially we had growth to our total contact cast application at the main campus here and throughout the region, which is good for our patients. And there's no doubt, if you haven't seen this slide before, the standard of care in healing a plantar neuropathic ulceration has to be a total contact cast. 92% cure rate within 6 weeks versus the average standard of care of 31% in 140 days. This is a patient I'd like to share with you. I do have approval to show his video here of his gait. I was told it would start this video, maybe? No? Can anyone start the video? Okay, great.
You can turn around now.
So this is a patient who had amputation. He was treated over the last 2 years here, multidisciplinary care, a very challenging case, 62-year-old male, kidney transplant, diabetes, uncontrolled, PAD. So I just wanted to ask your audience here, what level of amputation do you think this gentleman had? We know he had an amputation there on the right side, and we'll go on and poll the audience here in a second. He's been walking for about 3 months here in this video. His surgery was about 10 months ago.
Good.
His final definitive surgery, I should say. He had multiple attempts at revascularization and pedal. So A, B, C, D, or E, please, if it's not working. I will give you that answer and move on. Okay. Okay, what did everyone say? Okay, if you said D, you were correct. This gentleman had a SYMES amputation. I just wanted to take 30 seconds to talk about a SYMES amputation because I do think it's a viable, definitive amputation level that may be an alternative to an above knee or below knee amputation. I gave you the gist of the story. Hallux amputation, partial first-degree amputation, went into TMA, ultimately went to open bypass to the tibialis anterior. And here we go through a SYMES amputation, a disarticulation of the foot, basically at the Chopart level, then a disarticulation of the talus, and then finally the calcaneus. It is a one-stage procedure. It was originally described as 2. Drill holes through the tibia, reattach that plantar flap, and then, of course, here we are today and in his brace. The bracing is essential. I have one orthotic company that I work with, so again, that's part of your team, but a very successful procedure in that we don't have the high mortality rate as documented as of yet, although less documentation, of course, than the below knee. We have improved function and longevity. I have a happy patient who is always hoping to avoid the below knee amputation. So I would say that this is a success in my hands for many patients and an alternative to an above knee and below knee. No matter what we're doing, whether it's an amputation or trying to prevent that amputation, we still have a few shared goals. Good blood flow, control and eradication of infection always. Aim for a good biomechanical result. We ideally don't want to be doing 5, 6, 7, 8 amputations, of course, on a foot. So thinking about that, what is going to hold up long term? Creating that stable soft tissue envelope, again, for a long-term biomechanical result, preventing re-ulceration. It's not good enough to say, we got this healed in 3 months or even 6 weeks. Can we keep it healed? Can we prevent re-ulceration? That has to be our outcome for a good result. And restoring mobility, improving quality of life. Thank you.
My topic is unusual vascular causes of lower extremity wounds. I have no disclosures. These are very common problems, lower extremity wounds, as you're hearing already. There are many common causes that we've heard about. There are multiple causes causing about 20% of leg ulcers. These are more common in elderly patients, as you've already heard. They can lead to significant morbidity and quality of life changes. A busy slide just talking about many of the different types of lower extremity wounds. Vascular, you've heard about already, neuropathic as well, metabolic, hematologic, autoimmune, exogenous, like heat, cold, chemicals, etc. Cancers, infection, you'll hear about later, medications, genetic defects, and skin disorders. So when looking at these unusual causes of leg ulcers, one must ask a number of questions. What did the ulcer look like at first? When did it begin? How did it develop? Was there trauma, infection, medication change, or burn? Has a patient had an ulcer previously? And if so, where was the location? And how was it treated? What type of intervention did they have? Is there a family history of leg ulcers? Is the ulcer painful? And then what drugs or medications is that patient on? And then going further, obviously, we will ask about peripheral arterial disease, venous disease, or lymphedema. These are questions that we would look at. Do they have diabetes, hypertension, hyperlipidemia? Have they had coronary artery disease? Do they have chronic kidney disease, thinking about calciphylaxis? Do they have a hematological problem, sickle cell or thalassemia? Do they have gastrointestinal disease? And Dr. Meyer showed you a case of pyoderma. Do they have rheumatological disease? And we'll hear about those next. Do they have a skin disease? Do they have a psychiatric problem? And what medications are they on? Do they smoke? Do they use drugs? What is their occupation? Are they on their feet for long periods of time? Do they have access to wound care? Can they do dressing changes if they have access to wound care? And that may be difficult in the obese or elderly patient. Are there factitious questions that they may have, a psychological history? And again, is there a family history? And then doing a physical exam, we've already heard about that. Obviously, you're going to look at color changes of the wound or the leg, do a great vascular exam, looking for edema, is there neuropathy, and then looking at the ulcer size, location, the borders, the wound itself, is it probed to the bone, looking at drainage, is it painful, and looking at the surrounding skin are all important to our exam. There are a number of routine studies that we will do on our patients and then special studies. Some of these I'm sure we'll hear about next, but looking for things like drug screen is often important, checking cryoglobulins, cold agglutinins, and cryofibrinogens, and then SED rates and C-reactive proteins. Wound cultures are generally not recommended unless there's really clinical evidence of infection and usually or purulence or ulcer progression. Biopsies are recommended if there is no improvement with the standard wound compression therapy after 4 to 6 weeks of treatment, and also you should biopsy all ulcers with atypical features. I think you've seen this slide already, the non-invasive diagnostic testing that one can do. Certainly we can do ABIs, we can do transcutaneous oximetry, we can do Doppler ultrasounds, MR, CTs, and angiography. And on the venous side, duplex, venous incompetency, plethysmography, contrast venography, and IVUS may be helpful in those venous patients or atypical ulcers as well. And then lymphatic studies, lymphoscintigraphy, and then abdomen or pelvic CAT scans. So let's talk about a few of them. I think we touched on it briefly. Berger's disease is a non-atherosclerotic segmental inflammatory disease. It affects arteries, veins, and nerves, generally males, but obviously seen in females who have nicotine use. Typically, these patients have digital ischemia. They may have arch or foot claudication. They may have Raynaud's phenomena, and they may have had episodes of superficial thrombophlebitis. The vasculitis is characterized by a highly cellular inflammatory thrombus with sparing of the vessel wall, and obviously treatment revolves around stopping nicotine. A couple examples. Here you see a toe ischemia with a little bit of superficial thrombophlebitis, and this is a slide just looking at that vasculitis and the highly cellular inflammatory thrombus. Now, calciphylaxis, very painful, often seen in areas of fatty tissue. It affects the abdomen, buttocks, thighs, and distal extremities. These lesions are ischemic and necrotic, and it's a disorder of calcium phosphate metabolism resulting in arterial calcification and end organ calcium deposition. Typically, these patients have end-stage renal disease, they're on hemodialysis, or primary hyperparathyroidism. The diagnosis, think about it, get a biopsy. They may have elevated parathyroid hormone levels, and their calcium phosphorus product is generally elevated. Wound care and dialysis, these are very difficult to treat. The antiphospholipid antibody syndrome, these are usually arterial venous involvements. They also have many dermatological findings, including livido-racemosa, purpura, ecchymosis, subcutaneous nodules, splinter hemorrhages, and fixed digital cyanosis. They're very painful. These patients will have elevated levels of anticardiolipin antibodies or IgG, IgM, or anti-beta-2 glycoprotein antibodies, or a lupus anticoagulant, and typically respond to anticoagulation, obviously good wound care, and maybe antiplatelet agents, another example of one. A brown recluse spider bite, I don't think we see this very often. This is a condition characterized by necrotic skin ulcers known as necrotic arachnidism. The treatment is mainly wound care. They may require surgical debridement. They may need sympathetic blocks for pain control. And here are a few examples that one might see. These are extremely painful and very difficult at times to treat. Now, frostbite, you can get ulceration from that as well. It usually affects older patients who have underlying arterial disease or diabetes, but there are many other risk factors, as you can see here, including alcohol use, sedatives, motor vehicle accidents, neuropathy. This occurs in patients exposed to temperature below the freezing point of intact skin. The severity is related to the duration of exposure. They may have hand numbness or clumsiness or lack of fine coordination. And as you can see, it affects the hands, feet, ears, nose, and cheeks most often. And removing these people from the cold and then aggressive treatment is important. Now, erythromelalgia, you may see this as a primary and secondary form. The secondary forms, I think, are more common that we would see, usually seen with an underlying myeloproliferative disorder. This is a small fiber neuropathy and a vasculopathy. And these individuals have a triad of erythema, increased temperature, burning pain. The hands and feet, and less often the face, are affected. These individuals have episodes that are aggravated by heat or exercise, and they have reduced quality of life and increased morbidity and mortality. And treatment, generally aspirin, antidepressants, gabapentin, or topical agents that are now becoming more popular. I suspect we'll hear more about rheumatoid vasculitis a little bit later, but this can affect the skin and peripheral nervous system. The ulcers are often found on the foot, but they may have digital necrosis. Diagnosis is biopsy, and treatment, usually steroids, methotrexate, or azathioprine. Now, this is a controversial ulcer. Whether or not it exists is hypertensive ulcer. It's usually superficial, most commonly found on the lateral ankle, and it results from ischemia caused by arteriolar lesions. These individuals have long-standing hypertension, often poorly controlled, and part of the diagnosis, they must have normal arterial disease. The treatment, control the blood pressure, antibiotics if infected. Now, we can have hematological diseases, sickle cell. This is a defect in hemoglobin S, and this leads to sickle shapes, as you well know, increasing blood viscosity, slowing blood flow, and resulting in clotting and tissue ischemia. The ulcers are typically found above the medial malleolus and may exist with underlying venous stasis disease. It's a common problem in these individuals, disabling. Treatment, increase their hemoglobin and exchange transfusions, and hydroxyurea. And another example here. A hemoglobinopathy of beta-thalassemia is common. It results from high fetal hemoglobin F and local tissue hypoxia from anemia and hypercoagulability. It is typically found on the medial or lateral malleolus. They are slow to heal, they're very painful, and treatment again may be hydroxyurea or chelation therapy and or transfusions. I just have a couple more. Malignant melanoma. These are suddenly rapidly enlarging pigmented lesions, irregular in shape, and changes in color should make you think about them. They can masquerade as a non-healing venous ulcer. They usually fail to heal properly, and a diagnosis is with biopsy, and then send them to an oncologist. Hydroxyurea, ironically, we use that to treat these disorders, some of them myeloproliferative disorders. It's a complication, usually, and can lead to cutaneous malignancies. The frequent site is the malleolus. They result from cutaneous anoxia. Treatment is simply discontinue the drug. And then lastly, drug-induced uncommon arteriopathies can result from sympathomimetic amines like epinephrine, norepinephrine, or inadvertent arterial injection. As you can see here, this individual underwent sclerotherapy and had a vessel injected that wasn't supposed to be, and obviously resulted in this complication. So I'm going to end that here with recognize and treat the underlying disease, accurate diagnosis, as you heard from Dr. Meyer, wound debridement, maintain moist, clean environment, minimize pain, and if the ulcer does not improve, biopsy it, and then consider adjunctive methods. Thank you for treatment.
Minutes. I will cover epidemiology, pathogenesis, clinical features of the skin ulcers, trying to distinguish a little bit between single organ vasculitis causing ulcers versus primary systemic vasculitis, and go over that difference, and one sentence about treatment at the end. So vasculitic ulcers are an emerging problem, a serious problem. It's more frequent than we suspect, and we can confirm diagnosis. It's a serious problem because it's linked to severe morbidity, sometimes death. It's a serious problem because definitive diagnosis is not always possible, and sometimes we have to make our treatment guidance and decisions based on a presumed diagnosis. It is a serious problem because treatment can be very difficult. Sometimes we are dealing with refractory, non-healing ulcers, drug toxicity from treatment that we use to treat them, and these patients suffer from frequent relapses. Now, what is the frequency of this problem? Of all chronic leg ulcers, vasculitis cause about 4 to 5%, and that's probably an underestimated number since we cannot make the diagnosis in all the patients. And from all primary vasculitis that can cause ulcers, what's the risk? Well, most of the vasculitis that can be associated with ulcers are small and medium vessels, although all of them can be. The risk varies depending on the underlying disorder or which primary systemic vasculitis we're dealing with, and it's up to 20% according to some series. But if you think of cryoglobulin, up to 80% of the patients can be affected with vasculitic ulcers. A very interesting large French cohort of systemic vasculitis, including PAN, GPA, AGPA, and MPA, and I'll go through more details about that, shows that of all these patients, 5% presented with cutaneous ischemia, 3% digital necrosis, and 2% necrotic cutaneous ulcers. What was important about this study is that cutaneous ischemia was not different with the vasculitis type, was more associated with smoking, coronary artery disease, and hypertension. Raynaud's was common at diagnosis, and it was an independent predictor of risk of a systemic relapse. So again, there was an increased risk of vasculitis relapse associated with the presence of cutaneous ischemia. And also, it was a poor long-term predictor of outcome of all the systemic vasculitis, including death. What about the pathogenesis? So if you think about ulcers, they are either of an inflammatory origin, inflammatory angiopathy, which defines vasculitis, or an occlusive angiopathy. Now, there is an immunological dysfunction behind the etiology of this ulcer, but it's a combination of genetic and environmental factors that leads to inflammation of the blood vessel wall, which causes vessel wall damage, and that defines vasculitis. More commonly in the skin, the postcapillary venules are affected, and the tissues surround the ulcer. Now, thrombosis, fibrosis of the vessel, local ischemia, and tissue necrosis results in the formation of ulcers. The main cell culprits are the neutrophils and early lesions, followed by lymphocytes, monocytes, and if one finds the presence of fibrinoid necrosis, that is highly suggestive of vasculitis. Finally, we have extravasation of red cells, and that's what leads to the clinical appearance of the lesions. And what are these clinical features? These lesions are usually evolutionary. They evolve from mild lividal to palpable purpur, nodules, sometimes hemorrhagic lesions that culminates in ulcerations. But sometimes in a lesser number of patients, ulcer can be the initial lesion. It can be single or multiple. Usually they're small, multiple, confluent, and local edema is very common. Patients complain of pain, severe pain, burning, and local neuropathic symptoms. They're more common in the lower extremities, much more common than the upper extremity. And when it comes to diagnosis, as it was mentioned before, histological diagnosis is ideal. But it's not always possible, and we still have to make a treatment decision for these patients. We're more likely to find this signs of vasculitis in the lesion if we biopsy recent lesions at the edge where there's no necrotic tissue, and we should always perform, in my opinion, which is a little bit controversial, direct immunofluorescence, because in a lot of times it helps with finding the etiology of the ulcer. And then finally, the diagnosis has to be completely confirm whether this is a single organ vasculitis affecting the skin alone or there's a systemic disorder underlying that is causing that ulcer. And we'll show why this is important. This is an example of an evolving lesion from non-palpable to ulcerating till to necrotic cutaneous lesion. Sometimes they are initial ulcers. If the cutaneous leukocytoclex vasculitis is isolated to a single organ, the skin, it can be caused by infections, medications, illicit drugs, rheumatic disease, and malignancies, but usually in the majority of patients, we're not able to find a cause. They can vary anywhere from very mild to severe single episodes, or they can be chronic or recurrent. Some patients have a spontaneous resolution. Some patients have refractory ulcers to treatment. The most common lesions is palpable purpur. If there's a rheumatic disorder underlying, rheumatoid arthritis, lupus superficial Sjogren's are the most common one, with 5% of these patients being affected. The primary vasculitis listed above are the ones that are usually associated with cutaneous ulcerations. This is examples of single organ with leukocytoclastic vasculitis with palpable purpur, or, as you see on the bottom, healed ulcers. Those were ulcers that were not evolving, but initial lesions. Cutaneous PAN are usually very tender nodules that ulcerate, as you can see on the other side, and there is a focus on one of the lesions. More severe lesions can be seen with hepatitis C related cryoglobulinemia. You see hemorrhagic lesions evolve into ulcerations. Dermatomyositis, which is more common in children to ulcerate, but it can be seen in adults as well. And rheumatoid arthritis. In less than 5% of the patients, you see skin vasculitis, which is usually associated with neuropathy as well. With better treatment and better control of the disease, we're seeing less and less of this complication. And PAN, which can be cutaneous or systemic polyarteritis nodosa, skin ulcers can be quite severe, but they can be responsive to treatment. There's a small subset of patients that are steroid refractory, and we have to use cytotoxic agent to control these lesions. They can affect anywhere in the body, more common in the lower extremities, and it usually spares the face. This is an example of cutaneous PAN. They are usually presenting with very tender nodules, subcutaneous nodules. If we leave them alone and try not to remove those nodules, they tend to heal better with just immunosuppressive treatment. However, this is an example of the patient that had surgical removal and had very hard time to heal and associated with infection with the treatment. And that's the one on the bottom. And on the one on the right, he healed very well. Now, another point that I want to make, and this is a patient with Wagner's or GPA that present with severe ischemic disease. Now, they can heal very well, contrary or different than other causes of ischemia. Vasculitis, for some reason, they can reconstitute the tissue very well with just immunosuppressive treatment. So if we try not to debride or do any kind of surgical intervention, some of these patients might heal very well, as you've seen in this picture, with just immunosuppressive treatment. This is an example of ulceration of the nodules. This is a granulomatous inflammation that is more commonly associated with Schuch-Strauss, but can be seen with any small to medium vessel vasculitis. It usually starts with a very small, mild rash, as you can see on the top, and evolves with these ulcerations. They can get secondary infections. If you biopsy these lesions, they're granulomatous vasculitis, and they were initially described with the Schuch-Strauss. This is an example of a patient that had a severe necrotic deep wound from PAN and healed very well with immunosuppressive treatment and had not had any recurrence of the disease. It was a single episode. In terms of treatment, the most important message that I want to leave here today is treat the underlying disease. Whenever possible, try and make an attempt to make a diagnosis of whether there is a primary systemic disorder that is leading to that vasculitic ulcer. Now, if there's none, if there is an isolated cutaneous vasculitis, we treat based on severity. Some patients might have a single mild episode and may not require any systemic treatment because they have spontaneous resolution. In my experience, that's the minority. Mild persistent or recurrent disease may require very mild treatment. We usually try not to be very aggressive if possible. We're using NSAIDs, Plaquenil, colchicine, Dapsone. These are some examples. If it's a moderate severity, corticosteroids are usually required. In addition to that, we might have to use immunosuppressives such as methotrexate, azathioprine, or sometimes mycophenolate mofetil. In severe cases, such as seen with cryoglobulinemia, higher dose of steroids are necessary, usually associated with cytotoxic agents, such as cyclophosphamide. We'd be using more and more of rituximab for some of these patients, and in more severe cases, plasma exchange might be necessary. So in summary, all vasculitis can potentially cause skin ulcer, more commonly small and medium vessels. Ideally, we should attempt to obtain histologic diagnostic confirmation, which may make a difference on treatment choices. Treating the underlying systemic condition is the best chance for the patient to achieve remission. And mostly important, cutaneous ischemia is being associated with an increased risk of systemic vasculitis relapse and mortality. And such poor long-term outcome may justify early aggressive systemic treatment. Thank you.
Good morning, I'm Kristen England. I'm one of the infectious disease doctors here at the Cleveland Clinic. We often get consulted on lower extremity diseases to try and determine whether somebody has an infection or not. It oftentimes seems like part of the admission orders when people come here to the clinic are to put them on vancomycin. So part of our job is to make sure that somebody really needs these. Oftentimes we're looking at these lower extremity wounds to see if there truly is an infection present, and if not, practice good antibiotic stewardship and stop the antibiotics. Let's look at a couple of these to see if these lower extremity wounds really are infected or not. As you can see here, this is a patient who was admitted who is 75 years old, had congestive heart failure, and we were consulted as the patient was being prepared for cardiovascular surgery to determine if this cellulitis needed to be treated. One thing to look at on this is the significant amount of edema that's in both lower extremities. Both lower extremities are involved, and when you see cellulitis, it very, very rarely involves both lower extremities. As you touched this, there was no warmth on these feet, no excessive warmth. There was blanching of the erythema that was there. And as you lifted her feet, you could see the redness start to resolve as you lifted them. So we deemed that this was not an infection here. This, however, showed a different patient who had one leg, the one leg that's covered, you can't see, but it was edematous, but it was not erythematous. The one that you're seeing here shows some erythema of the foot. It was warm, it was tender, and you see a skip portion over the ankle, but on the lower portion of her leg, there was some erythema there as well. It's not uncommon for us to see erythema and cellulitis skipping the ankle joint area, but extending onto the lower extremity. So this was a true cellulitis. This is an ulcerative disease on the lower extremity, and it's caused by an infection. The infection is HHV, human herpes virus 8. For those of you who are too young to see this, it's Kaposi's sarcoma, and we see this in our HIV positive patients. You can see the really violaceous appearance of these wounds, and they do ulcerate and can be quite tender. This was a patient who was a 68-year-old gentleman who'd stepped on a nail. Previously, about 3 weeks before, he'd had his great toe amputated as a result of that, but he was doing well and then developed a very rapidly progressive lower extremity erythema that devolved very quickly into this necrotic area. He was quite ill when he came in. Blood cultures showed that he had a group A strep bacteremia, and you can see the area of necrosis that developed very quickly. It extended up his lateral thigh, and on the medial thigh, you can see one area of lymphangitic spread. He also had some tender inguinal lymph nodes. He did go to getting a pretty significant surgical procedure to debride this, and it was evolved quite a lot more than you could see just on the skin from the necrotic area. This is an elderly patient who was quite malnourished, came from a nursing home. He had a number of ulcerative diseases, as you can see, ulcerative wounds on the lateral aspect of his left leg. But the one that I want to focus in on here is the one over the lateral malleolus, where you could actually touch the bone that was there, the bony protuberance that's there. I know we talked about plain films and getting MRIs, but frankly, from my perspective, if I can touch bone, there's osteomyelitis there, I don't care what the x-ray shows, I'm going to be treating that patient for 6 weeks. It's certainly helpful if we can get a deeper, say, a bone culture or get a bone biopsy for culture on this. It's difficult sometimes for those to heal, so as much as we don't like superficial cultures, that was the best that we could do at this point in time. This was a 90-year-old woman who came in, and she'd hit her leg on the edge of the bed in her nursing home, and this was simply failing to heal. She had a superficial culture, again, not the best opportunities to get a superficial culture, but for here it was certainly the best we could do. We didn't want to do anything more to damage her. And you can see the erythema that is surrounding this ulcer. The ulcer edges are not undermined. And over the top of the wound, she's got a fibrinous, purulent material there. That was what was cultured. She was treated with IV vancomycin, and as you can see, just a couple of days later, the erythema was markedly better, and the wound, with some appropriate dressing changes, was looking markedly improved. So this is a young nurse. She had some left foot trauma as she hit it on a patient bed. She had several debridements with worsening and progression of the lesions after a couple of INDs. So I want you to answer this. What antibiotic would you choose for this patient? Piptazo, Vanco, clindamycin, Ampsulbactam, ciprofloxacin, or none of the above? Fantastic. As you remember my first statement, some of these are not infections, and part of my job is to get on board and make sure that we're stopping antibiotics when they're not needed. This is another patient. That first patient had pyoderma gangrenosum. This is another patient who presented to see one of my colleagues from a wound clinic that had been going on for months, getting serial debridements for this wound. As you can see, some of the edges are quite undermined, a little bit violaceous. The patient had actually done a great job of documenting the progression of their wounds over this period of time, and as you can see, it started off almost looking like an eczematous lesion, then moved into a more necrotic appearing wound, and then finally developed the significant ulcer that was there. There's no erythema around the edges of this. It's just simply the violaceous edge that's undermined. This is a patient who had pathergy, had a saphenous vein graft. The sites did not heal. This is not an infected wound. This is simply an ulcerative, chronically inflammatory wound that is exhibiting pathergy. This is an up-close picture of that. Diabetic foot ulcers are something that we commonly see, and as you can see, there's the marked erythema of this foot here. And the IDSA guidelines talk about for the diabetic foot infections, the evidence of infection is typically are rubor, calor, tumor, and dolor. There are purulent secretions there. Some secondary signs can be the friable or discolored granulation tissue, and then the undermining of the wound edges that you saw in that prior patient, and then a foul odor. Oftentimes you're walking in the room and you can tell right away by the odor in the room that this is infected. Things that I typically will be looking for is the probe to bone test. Again, if it probes to bone, it's osteomyelitis. I don't care what the x-ray shows. An ulcer that's been present for more than 30 days, recurrent foot wounds, traumatic, the presence of peripheral vascular disease, a previous lower extremity amputation, loss of protective sensation, renal insufficiency, and a history of walking barefoot. This was an unfortunate patient who has diabetes, end-stage renal disease, had a beautifully done transmetatarsal amputation, went to a skilled nursing facility, and the dressing remained unchanged for over a week, which harkens back to Dr. Meyer's conversation that dressing changes really do need to be changed more frequently than that. The wound was purulent, had a significant odor to it, and most of the metatarsals you could actually probe directly to. We talked a little bit about wound cultures, make sure that they are coming from deep wounds. I'm not going to go into the microbiology of this at this point in time. Talking a little bit about the vascular rheumatologic disorders. This is a patient with scleroderma. There was certainly a lot of necrosis here, but also at the base of the small toe, you can see it's markedly enlarged. It was wet. This was wet gangrene. This needed to be treated not only for the scleroderma, but for the infection as well. Ultimately, she required a transmetatarsal amputation. Another type of infection that we don't often see, thankfully, but can result in necrosis, purpura fulminans, due to a streptococcal pneumonia infection in this 12-year-old, resulted in significant necrosis of her toes. And lastly, this is a necrotic thigh from what? There was a bit on Dr. Bartholomew's slide that he did not quite get time to cover, but this is something called levamisole. This is present in cocaine right now, cut into cocaine and also cut into some of our heroin that we're seeing. We're seeing an absolute epidemic of IV drug use in this country. This looks certainly necrotic. It is a vasculitis that you see as a result of the adulteration of the cocaine from that. And that's it.
So obviously we discussed the issue of perfusion assessment, folks before me highlighted these. I just wanted to highlight what are the tools that are available, what are the limitations for you. As you can see, the patients come to you, they don't tell you I have CLI, they have an ulcer. And we always make a teaching point that, ulcers happen for a variety of reasons. Actually, it's rarely that is the PAD that's causing an ulcer. It's usually pressure, trauma, infection, or iatrogenic. Once the patient has the ulcer, then you want to ask the question, is the ulcer going to heal? Meaning that is there enough perfusion to heal the ulcer? So obviously everybody knows about ABI. When the ABI is abnormal, everybody is happy. They know that there is PAD, and you call your favorite interventionalist to treat. But unfortunately, in many cases, patients present like this, a patient with full thickness ulceration of a distal foot, and they heal. You do an ABI, and the ABI is 1.12. And then you look at the waveform, and they look pretty reasonable. And you're asking yourself, well, what's going on here? Is this just a diabetic pressure ulcer, or is this someone with significant vascular disease in addition to the fact that they have an ulceration? You look at their angiogram, you see that the AT and the proneal, the proneal and the PT are occluded, and then the AT has diffuse disease. So there's a misconnection between what the ABI tells you and what the degree of disease is. And we showed this with actually one of my former colleagues, who is actually a faculty here, Dr. Bunty, about a year and a half, 2 years ago, that 29% of the patients that present with critical limb ischemia actually have an ABI that's normal or near normal. So if you rely just on the ABI, you're going to miss a significant number of patients with critical limb ischemia. And we showed that if you look at the correlation between ankle brachial index and Rutherford class, actually those that had the Rutherford 6, meaning the worst CLI, actually had the higher ABI compared to those that had the 4, rest pain. Because remember, rest pain is usually aortoiliac inflow disease. So these folks tend to have lower ABI than those that have Rutherford 6, which is your diabetic, your end-stage renal disease patient that has isolated below knee disease, and actually their ABI may even be higher. And then we looked at the ankle brachial index and the Rutherford class. Again, we saw this paradoxical association when those that had 3-vessel runoff had actually lower ABI than those that had no vessel runoff. Again, the 3-vessel runoff means someone that has aortoiliac disease, so their ABI is lower. Now, there has been a number of guidelines in trying to teach us what the perfusion cutoffs are for ABI. There is the ACC guideline, there's TASC guideline, the Society of Vascular Surgery guideline, and many others. I've just highlighted a few. And the question is that how accurate are these guidelines in assessing perfusion in patients with critical limb ischemia? And this is actually a document that Dr. Patel led, the PARC guidelines in trying to identify perfusion assessment in patients with critical limb ischemia. But as I showed you earlier, we were seeing these patients with significant CLI, and we were noticing that their ABI was actually normal or near normal. And there was a disconnect with what the guidelines recommended and what we were seeing in the clinic. So we then asked the question from this database from Impact Deep, over 250 patients, and we wanted to know what was the accuracy of the guidelines recommended perfusion assessment in patients with known critical limb ischemia and isolated or significant below knee disease. This is a study of drug-coated balloon for below knee disease. And what we showed was something very interesting. What we showed that if you use the guideline recommendations, even in this study, which is a multinational study, international from Europe, over 28% of the patients had normal or near normal ABI. You can see those are patients with 3-vessel disease. If you look here, 3-vessel disease, 28% have an ABI of either above 1.4 or normal ABI. If you look at those with 2-vessel disease, so you can see that the proportion is even significantly higher. So you can't just rely on ABI or ankle pressure. You have to use other tools. And we even looked at the toe pressure, and you can see even among toe pressure, a significant portion of the patients have an ABI that is normal. So normal ABI shown in yellow, even the toe pressure was abnormal. You can see that the ABI, 29% of the patients was normal. So toe pressure may give you some additional information in patients that have normal ABI, but you suspect CLI. And again, we showed the correlation that toe pressure was more useful. The other issue is this issue of angiosome. And we discussed earlier, Dr. Meyer, about the 6 angiosomes, the AT supplying the dorsum of the foot, the PT supplying the plantar aspect of the foot and the heel, and the proneal, the lateral aspect of the foot. So we had this 62-year-old gentleman with severe diabetes, prior left below-knee amputation, hypertension, hyperlipidemia, and you can see the patient presents with this large heel ulcer. But if you look at the ABI, you see that the ABI is actually 1.17. But the ABI that's provided is from dorsalis pedis. And if you think about the angiosome, and we apply the angiosome in the clinic, not necessarily just in the lab when we want to open the artery. So in the clinic, when you're looking at the patient, you see that the DP is the ABI that's provided. But when you look at the PT, the one that you're interested in, given that the ulcer is in the heel, the ABI actually is 0.69. And if you look at the TBI, to give you a little bit more information about distal disease and microvascular disease, you see that the patient's TBI is 0.21. We use a cut point of 0.65, 0.7 here at the Cleveland Clinic. And in this case, unfortunately, this patient, because of the normal ABI, was treated medically. So aggressive wound care, hyperbaric oxygen, trying to heal the patient. And you can see that over time, the ulcer did not heal, actually enlarged and more necrosis. And at this point, there are other tools that can potentially help you. So if you don't want to go directly to an angiography, and many folks out there, and some of you may be sitting there, would say that, listen, I would angio that patient with that ulcer anyway, diabetic patient, prior below-knee amputation. But this doesn't happen. Remember, we show you the data. 40 to 70% of the patients don't get any kind of vascular intervention the year prior to the amputation. And Dr. Patel showed you they don't even get a perfusion assessment in the year prior to the amputation. So even though many of you may say that I would do an angiogram, this is not happening out there. And these ulcers, as you know, heel ulcers, once they get osteomyelitis, we are now talking about below-knee amputation and extensive morbidity, and the patient already had a left below-knee amputation. So the other tool is transcutaneous oxygen saturation. This measures oxygen tension 1 to 2 millimeter deep in the skin, but it can also provide you some guidance as to whether the patient can respond to hyperbaric oxygen therapy. The cut point that's been typically recommended has been 40. But this technique can be affected by a number of other issues, such as edema, skin thickness, the temperature of the room, and is a little bit cumbersome, may take a couple hours to do, to perform. In the patient I showed you with a heel ulcer and a normal ABI, this was actually TCPO2. And I can tell you that you rarely see these. This is says 30, 14, 13, and 7. And so you can see that the patient with a normal ABI and decent waveform having this kind of a TCPO2 that very few people would argue requires attention. And you can see here that we can then give the patient oxygen and we can assess whether they respond to oxygen. And some folks have used that as an indication that maybe the patient will benefit from hyperbaric oxygen therapy. Now, this patient fortunately had very simple anatomy to treat, honestly. We didn't have to spend a couple hours to treat. You can see that the patient had popliteal disease, but also has proximal AT disease. There is some tibioperoneal disease and some PT disease that needed some work. And in honestly, a very little endovascular intervention, we can then become aggressive and use Dr. Meyer's help. And as you can see here, over the few weeks, 2 weeks, 10 weeks, and 30 weeks, with his work and his aggressive wound care, we are able to heal this patient who already has an amputation on the other side. There are other modalities, such as the skin perfusion pressure. This measures capillary opening pressure, so it's not affected by the edema, the callus, and other modalities or other issues that these patients usually present with. Many folks use this technology because it's also easier to perform. Again, the cut point of 30 to 40 is considered as non-healing in these patients. And if you compare the two modalities, remember one measures oxygen molecule, oxygen tension, the other measures pressure. And obviously, SPP is not affected by edema, callus, and room temperature. Other technologies that are being evaluated, they are not readily available now for clinical use. There is endocyanide green, which measures tissue surface viability. It's been used in plastic surgery and gut surgery. Basically, you inject endocyanide green, and then you can take pictures of the foot before and after the procedure, or even in the clinic, to try to assess microcirculation. This technology obviously is not ready for prime time, in my opinion, but is currently being evaluated to assess microcirculation. There are other modalities. One of my close friends and colleagues, Dr. Mena, who is also a faculty here in this symposium, they published this work using actually SPECT CT imaging
to try to assess perfusion in the foot, especially related to angiosome approach. And there are other approaches. This is, again, a good friend, Dr. Montero Baker, who is also a faculty in this meeting, who published this work using a micro-oxygen sensor that's implanted in the foot and actually measures oxygen indices, relative oxygen indices in the foot, trying to give you information during the operation or procedure as to whether you have provided adequate perfusion, and then also in follow-up in these patients with critical limb ischemia. Again, with that, I'm going to stop. Thank you very much for your attention.
Today, my talk is about like a non-invasive assessment in limb ischemia, critical limb ischemia. As you know, there are 3 modalities: duplex, MRA, and CTA. I'll try to cover all these 3 modalities. Duplex imaging is a combination of a grayscale and a Doppler imaging. It has its own limitations. Predominantly, it's a high operator dependent. The others are related to patient, which are like bubble gas, tortuosity, or heavy calcification. This reduces the accuracy of the study. These can only see bits and pieces. That's the other disadvantage of the duplex scanning. So for comprehensive review, a CTA and an MRA is very useful. In general, when should one order imaging in PVD? To screen asymptomatic patients, to confirm PVD in symptomatic patients, or to plan revascularization when symptoms are poorly controlled. Okay, that's the right one. Oh. Yeah. There's like a non-departmental public body in the UK, which is known by name of NICE. According to their guidelines, imaging is recommended if revascularization is being considered. And their line of planning is a duplex followed by an MRA and followed by a CTA. And there's other guidelines by the American College of Radiology, ACR appropriateness criteria. They give a scoring from 1 to 9, and as the number increases, the appropriateness increases. And according to them, as you can see, CTA, MRA, and the duplex has got like 7 and 5 compared to the DSA, which is 8. This is specifically in a patient with a sudden onset of cold and a painful leg. What is the comparative evidence in PVD? Compared to MRA, CTA is more sensitive and more specific, less sensitive and less specific, more sensitive but less specific. A little. Okay, it's less sensitive and less specific. Let's see. Okay, we'll see. There was a review, a systematic review by Collins and team. They reviewed about 100 studies, and according to them, for the detection of greater than or equal to 50% stenosis or occlusion, the median sensitivity and specificity of MRA is greater than 95%. When you compare the other ones, it's just around 90. The duplex scan is 88 and 96%. What are the recommendations in limb ischemia? These are the guidelines by the American College of Cardiology and American Heart Association in 2005 and 2011 compilation. What they suggested, on your left you see the indications and the right class of recommendation based on the level, degree, and selection of the endovascular and selection of surgery and follow-up. 1 and A are the strongly recommended, and 2B and lower than that one are less recommended. CTA to be used if MRI is not an option, but there's always a concern for radiation, there's an anxiety, and in radiology we always say LR principle, which is as low as radiologically applicable principle to use less radiation. Coming to the economics, compared to duplex-based imaging strategy in PVD, CTA-based strategy is expensive, comparable, cheap. I'll talk in the next few slides why is the strategy of the CTA is cheaper. As you see this one, there's a proportionate, as you see on the left side, the MRA has got proportionate increase in the relative cost. On your right side, you see the ABI, which is not reimbursed, and that's why you see there's no like proportionate cost there. And there's a multi-center trial which was done, it's called DIPAD trial, which reflects an actual practice. According to them, if you look at the top, this one is like representing duplex scan versus an MRA and a CTA. The initial cost for a duplex scan is very, very minimal. As these patients will go on to have additional imaging, the cost goes on adding up. And when you compare the overall cost on the top left to the down, which is comparison of an MRA versus a duplex and a CTA, the MRA has got initial cost is high, but overall cost as you go along, the number of additional imaging is less. So when it comes to one size does not fit all, there are contraindications for MRA. There are like the big list. So what to do in these cases? Maybe this is a patient who needs a CTA. And what if there is a clinical urgency? CTA takes about 10 minutes, whereas MRA takes about 40 minutes. And do you suspect any severe calcifications? On your left side is a CTA, on the right side is an MRA. Both has got like plus and minuses. On the left, the CTA is very good for looking at calcifications, but if you overshoot or if the timing of the study is not adequate, maybe you are contaminating, and a venous contamination will undermine your diagnosis. What if EGFR is 30 to 60 in a CKD? Iodine-based CT contrast, we can lead to contrast-induced nephropathy. CTA is relatively contraindicated, but we can always give hydration if required. In 30 to 60, gadolinium-based MR is not contraindicated. What if the GFR is less than 30 in CKD patients? There is a complication, which is gadolinium-based MR contrast, which can cause thickening and hardening of the skin. There's about 4% incidence in CKD, which could lead to 30% of mortality. And in these scenarios, maybe a duplex scan might have an advantage. There are other additional sequences in MR, which are non-contrast MR, which is like without any gadolinium, is possible. There is a high negative predictive value of 92, but it's prone to very serious artifacts, which leading to 47%. And in summary, it's a big, busy slide. I think it's there in your text, which we try to differentiate like what is the indication and what's the role of MRA, CT, and duplex scan. The take-home message is a non-invasive imaging, MRA, duplex. All three of them has got their own like limitations and advantages, but based on the literature, I think this should be like MRA to start with, to looking at your cost and everything. I think there are always additional sequences in MRA. I think best to talk to your local imaging specialist.